Chair will recognize himself for an opening statement. During the last several years, there have been few areas of agreement between Republicans and Democrats on how our health care system should be reformed to better serve patients. From the beginning, however, one area that both sides have designated as a top priority is coverage for those with pre-existing conditions. In the Republican alternative to Obamacare, we proposed $25 billion over 10 years to aid Americans suffering from pre-existing conditions through new universal access programs that reformed and expanded state-based high-risk pools and reinsurance programs. Unfortunately, Obamacare provided only $5 billion in the pre-existing condition insurance plan for this purpose. PSIP, we'll call it, for this purpose until January 1, 2014. At the time of the health care law's passage, Republicans argued that the funding level was too low and would not cover all of those it was meant to help. The first real signs of trouble for the federally administered high-risk pools came in August of 2012 when CMS reduced payments to providers treating a high number of high-risk pool enrollees, hitting hospitals especially hard. Additionally, the agency cut the number of participating pharmacies that provided certain types of drugs to program enrollees. Next, on January 1, 2013, CMS increased the maximum out-of-pocket cost for program enrollees by $2,250 and mandated greater use of mail-order pharmacy. Finally, on February 15, 2013, CMS announced that it was suspending enrollment in PSIP altogether due to financial constraints. All of these actions were taken despite the fact that enrollment in the high-risk plans was less than 30% of what had been expected. Original estimates were that 375,000 people would sign up for the federal high-risk pools. In fact, only approximately 110,000 individuals have joined. CMS is now trying to stretch what is left of the initial $5 billion to cover those already enrolled in the program until January 1 of next year. What will happen to those people who had pending applications for PSIP when CMS cut off new enrollment? What about those, by some estimates, 40,000 people who would have enrolled during the remainder of this year? They are left without options and without coverage. On March the 5th, Speaker Boehner, Leader Cantor, Whip McCarthy, Conference Chair McMorris Rodgers, Chairman Upton, Dr. Burgess, and I sent a letter to the President asking that he redirect funding from other Obamacare accounts to PSIP to allow the program to continue accepting new enrollees. Although we still hope for a full repeal of the health care law and to replace it with other reforms, we've reached out to President Obama and asked him to work with us to help those most in need to get coverage and care. We are still awaiting for his response. I want to thank all of our witnesses for being here today. I look forward to your testimony, and I would like to conclude my statement at this time. And since we do not have any of the minority members here, I will recognize the Vice Chairman of the Subcommittee, Dr. Burgess, for 5 minutes for his opening statement.
Well, I thank the Chairman for the recognition. I also want to thank the witnesses for being with us today. I appreciate you making the effort to be here because this is an important issue. Some of you I have met before. For others, this is the first time, but welcome all. We hear a lot that Republicans don't have alternatives or other ideas for the replacement of the President's health care law. I know this is untrue. Many of you on the panel know it's untrue. If anything, our party has a multitude of ideas. But one overreaching aspect of policy that there seems to be general consensus is we do need to address the needs of Americans with what are called pre-existing conditions. As the chairman said, the Affordable Care Act created the new pre-existing condition insurance plan, affectionately known as PSIP. I think I'll refer to that as a federal plan so it won't be confused with state plans. But it was arguably duplicative of actions taken by 35 states prior to 2010 that were operating high-risk pools. They served an estimated, well, over 200,000 Americans. It's been shown that state-based programs do play an important role in lowering the costs across markets and providing coverage options for those who are faced with a pre-existing condition. In some states, the federal pre-existing program was merged with the state's existing high-risk pool, and in others, like my home state of Texas, the PSIP plan operates parallel to the state's pool. However, the federal pre-existing plan is providing coverage to 100,000 individuals, well short of the 375,000 that CMS estimated, but still a significant and a compelling group of people who all have stories and deserve protection. As a physician, ensuring those with pre-existing conditions and assuring that they have access to affordable health insurance is a top priority for me. As much as I believed that the President's Affordable Care Act stretched the bounds of constitutionality, and in fact, I still believe that, I was concerned that if the Supreme Court felt as I did that day and said, look, this thing is outside the bounds that the Constitution places on the legislative branch, that folks were going to have the rug pulled out from under them who had been in the federal pre-existing program and then could be barred from merging into a state's pool because the federal program had previously provided them coverage. That's why, to ensure that that did not happen, I was prepared to answer that challenge and introduce the Guaranteed Access to Health Insurance Act of 2012 prior to the court's decision to provide states with the financial backing to decide how best to provide coverage for their populations who would be in this risk pool. I will also note that unlike many of the complaints that the federal pre-existing program has faced, the bill did not require those with pre-existing conditions to jump through hoops or to remain uninsured for some unreasonable period of time before being eligible for coverage. There are always stories of those who have done the right thing, insured themselves, and then for reasons kind of beyond their control fall out of the system. They lose their job, they get a tough medical diagnosis, and then find themselves forever frozen out of coverage. Those were the stories that people thought of. And people did come to us with that concern. In the summer of 2009, many of you remember the rather tense town halls that were held across the country. What did people tell us? Yeah, they were worried about people with pre-existing conditions. They didn't want us to mess up what was already working for arguably 65 or 68% of the country. And they sure wanted some help with costs. And turns out we failed on all three accounts with the Affordable Care Act. How many people have aged into this 6-month exclusion since the Center for Medicare and Medicaid Service made the announcement that the federal program was now closed? Someone who said, well, I'm going to start the clock in October and I'll be able to enroll in April, now finds themselves frozen out of the system. Was it because that the federal pre-existing program was designed poorly because its costs were too high? Was it because maybe the problem of serious pre-existing conditions existing in a population that wanted to purchase insurance was lower than estimated? We'll never know, but it would have been nice to think these things through prior to adopting the Affordable Care Act. I will admit that many of the current state-based programs are underfunded and lack the ability to meet their needs. It's costly to deal with these issues. These people are sick. They have multiple medical conditions. I was prepared to authorize $30 billion. $5 billion was what the federal program allowed. I was prepared to authorize $30 billion. I got people back in my district who say, Dr. Burgess, $30 billion, that's way too much money. We don't have the money. Well, I'll tell you what, it's a lot cheaper than the $2.6 trillion that this thing is going to cost, and we wouldn't have had to blow up the whole system in order to take care of those people that arguably are going to need help. If we're serious about funding these programs and dealing with these issues, these costs are but a drop in the bucket as to what the Affordable Care Act will cost our nation. And Mr. Chairman, I see you've already been generous with the gavel. I've consumed the time that you yielded back and my time as well. I have considerably more, and I will provide that for the record and anxious to hear from the witnesses, so I yield back.
Chair, thanks, gentlemen. And we do have statements from the ranking members, Pallone and Waxman, and I'll ask unanimous consent to enter those into the record without objection, so ordered. We have one panel today, and I'll introduce them at this time. On our panel, I'd like to thank them for taking time to come and share their expertise with us today. First is Mrs. Susan Zerfus on behalf of the Leukemia and Lymphoma Society. Secondly, the Honorable Mary Taylor, Lieutenant Governor from the state of Ohio and Director of the Ohio Department of Insurance. Thirdly, Dr. Sarah Collins, Vice President of the Commonwealth Fund. Fourthly, Mr. Ron Pollack, Executive Director of Families USA. And finally, Mr. Thomas Miller, Resident Fellow of the American Enterprise Institute. Thank you all for coming. Your written testimony will be made part of the record. We ask that you summarize your testimony and opening statement of 5 minutes each. Ms. Zerfus, we will start with you. You're recognized for 5 minutes for your opening statement.
Thank you. Mr. Chairman and members of the Health Subcommittee, as a patient with blood cancer, it is my honor to share my experience and those of other blood cancer patients as they've attempted to utilize the pre-existing condition insurance program. I'm a 42-year-old single mother with a full-time legal career. I live in rural southern Ohio in an area that has been clearly affected by the economic recession. I'm a solo practitioner with a modest law practice, a sizable portion of which is dedicated to serving indigent clients. I have 2 children who thankfully have coverage under their father's medical plan. I am active and I strive to keep myself healthy. For the last 13 years, I've rarely been ill and I've not needed health insurance coverage. After my mother's death in September of 2012, I became ill, and after nearly 8 weeks, I ultimately saw my family physician and a series of tests were ordered. A week and a half later, on January 9th, I received the first test results confirming a diagnosis of chronic lymphocytic leukemia, CLL, one of the most common types of adulthood leukemias. The bill for that analysis alone was $7,600. After follow-up tests and a 3-day stay in the MICU at Wexner Ohio State University Medical Center, I received over $50,000 of medical bills that I could not afford. Thankfully, the social workers at the hospital immediately enrolled me in Ohio's Hospital Care Assurance Program, HCAP. Because my income met the threshold for eligibility, I currently have 100% medical coverage. Eligibility for HCAP is reviewed quarterly. I've been working full-time since the beginning of February, so I will likely lose eligibility for this program. In late February, I learned about the Ohio High Risk Pool program. Just before sending in my application, I learned that the program was no longer accepting new patients due to lack of funding. My options are limited. I cannot qualify for Medicaid unless my income is low or I become disabled by my CLL, and I cannot afford high premium or high deductible plan. If I'm working at a normal capacity, I will almost always exceed the level to maintain continuous assistance through HCAP, but not by enough that makes health care affordable. Even without costly treatment, my CLL requires regular medical care, blood screenings, and screenings for secondary cancers. Without the benefit of coverage, I have 3 options. Do nothing at high financial and health risk, declare medical bankruptcy, or enroll in clinical trials out of financial, not medical necessity. The Leukemia and Lymphoma Society has identified 3 barriers that exist in this program. First, the 6-month wait without health insurance that a patient must endure before becoming eligible to enroll. Second, premiums that are prohibitively high. And third, the lack of portability across networks. I've submitted a representative sample of stories from patients who have been working with LLS as part of my written testimony. When seriously ill patients are forced to go uninsured for 6 months, they risk deeper illness or death, bankruptcy, and/or the potential loss of their homes. This barrier cannot be changed through the regulatory process. We urge members of Congress to work together to remove this barrier legislatively. A second significant barrier is the relatively high cost of coverage. Nearly 80% of the uninsured with high-cost chronic conditions are individuals with incomes less than 400% of the federal poverty level. who will likely find PSIP premiums unaffordable. Future enrollees in the exchanges will be provided subsidized premiums and out-of-pocket spending caps. However, that's not the case with PSIP enrollees. Furthermore, a small subset of states, including Pennsylvania and several others, have exacerbated the problem by prohibiting third parties from assisting patients by covering the cost of PSIP premiums. We urge members of Congress to enact common sense reforms to the PSIP program, including providing premium support for those patients who may need assistance and by allowing patients to receive third-party non-government assistance. One final barrier that patients experience in PSIP is a lack of portability across networks. For many patients, once they have begun their care within a network, it is emotionally difficult and cost prohibitive to reestablish relationships with new providers. The PSIP allows patients to visit providers outside of a participating network. However, the out-of-pocket deductibles are double those within the network. There's no out-of-pocket cap, and a 50% coinsurance is added to any services obtained. We urge members of Congress to provide patients with the flexibility needed to obtain the health care they require. On behalf of the Leukemia and Lymphoma Society, myself, and the over 1 million patients living with or in remission from blood cancer, thank you for the opportunity to speak with you today. We urge Congress and the administration to work together to ensure continuity in the program, as well as policy fixes that could make it even more helpful for patients who so desperately need it.
Chair, thanks, gentlelady, and especially thank you for sharing your personal experience and for these recommendations. Chair now recognizes Lieutenant Governor Taylor for 5 minutes for opening statement.
Mr. Chairman and distinguished members of the committee, thank you for the opportunity to testify this afternoon regarding Ohio's experience with the high-risk pool program under the Affordable Care Act. My name is Mary Taylor, and I am Ohio's Lieutenant Governor and also the Director of the Department of Insurance. States have regulated insurance for decades based on the specific needs of their populations, economies, and insurance markets. Under the leadership of different administrations, Democrat and Republican, over the past 60 years, our department has managed and regulated a competitive insurance market for consumers and job creators. Because of our regulatory environment, Ohio has a very competitive health insurance market with 60 companies writing health insurance business from which Ohio's consumers can choose. In order to determine the impact of the ACA on Ohio's vibrant market, my department commissioned a report conducted by Milliman, Inc. in 2011. This report projected premiums would increase in the individual market in Ohio between 55 and 85%. In addition, the report projected a substantial shift in how people get their coverage, and as a result, the size of the individual market in Ohio is projected to more than double, while the employer-sponsored insurance market is decreasing. In addition to these impacts, the ACA does little in the way of reducing the underlying cost of care that has historically driven the increasing cost of health insurance coverage. This law is a one-size-fits-all national approach to health care that removes the flexibility from states and is laden with very narrow and rigid regulations. More specifically to the high-risk pool. The high-risk pool concept can be a useful tool to address access to health insurance coverage if done well. However, implementing them as mandated in the ACA is problematic. The federal government's poor management and oversight of the program led to its unsustainability and ultimately the untimely decision to close an enrollment in the program for new participants, leaving a very vulnerable population without access to insurance coverage. Ohio's high-risk pool was organized in 2010 and is administered by an Ohio licensed private health insurer, but it is funded by HHS. Our department retained its general regulatory authority over the high-risk pool, including the right to review premium rates and resolve consumer appeals. Even though the program administered by Ohio was among the most efficient and cost-effective in the country, the federal management of the high-risk pool program quickly caused disagreements between the two agencies. In 2011, the high-risk pool submitted rates to both HHS and the Ohio Department of Insurance for review and approval. The Department of Insurance approved the rates that were actuarially justified for the two high-risk pool plans using our normal processes. However, HHS refused to approve the rates and directed the Ohio High Risk Pool Administrator to artificially reduce rates for those in the lower deductible plan and artificially increase rates for those in the higher deductible plan. As regulators, we must ensure that each block of business is solvent and that one pool of individuals isn't subsidizing the cost of another pool of individuals. As a CPA and insurance regulator, where a primary concern relates to company solvency, forcing a company to artificially set rates causes serious solvency concerns and potentially puts the company at risk where it can't pay the health claims incurred by those individuals and families who have insurance coverage under the plan. Eventually, HHS and the department were able to come to an agreement on rates, but of course this caused consumer confusion and pushed back renewal dates. Shortly after the problems with the rates were resolved, we began having eligibility disputes with HHS. As the primary regulator, the department reserved the right to make final determinations on eligibility. But in these cases, HHS demanded the Ohio High Risk Pool Administrator ignore the department's determination and instead follow HHS's directions. Ohioans who were clearly eligible for the high risk pool, according to our department's review, were forced out of the program by HHS, causing them to lose their only available source of coverage. After protracted discussions between the department, the Ohio administrator, and HHS, it became clear that HHS would not recognize the department's authority. The Ohio administrator was then forced to file a lawsuit against both parties, seeking clarification from the courts as to which party they were bound to follow. An agreement was eventually reached in which the department's regulatory authority was upheld, but this several-month-long ordeal demonstrated the federal government's propensity to overreach and disregard state regulation of insurance that resulted in harm to consumers in the process. While our pool has come with challenges, to say the least, we feel this tool is not without merit. However, as you seek additional funding to allow this program to continue through 2013, we encourage you to ensure states are given control and flexibility. Just as with the high-risk pool in Ohio, when a federal agency steps into a role in which they do not have the experience or the expertise to properly understand the issue, it can have severe consequences for the market and consumers. Knowing the challenges that lie ahead, I encourage members of Congress to continue working toward a better solution. We will continue our work to improve quality of care in Ohio, reduce costs, and truly reform Ohio healthcare system. Thank you for allowing me the opportunity to testify before you today, and I would be happy to answer questions that you have at the chairman's request.
Chair thanks the gentlelady for her statement, and now recognizes Dr. Collins for 5 minutes for opening statement.
Thank you, Mr. Chairman, for this invitation to testify on the Affordable Care Act's pre-existing condition insurance program. The major coverage provisions of the Affordable Care Act go into effect in January 2014, providing new insurance options for people without health insurance and sweeping new insurance market reforms to protect people who must buy health plans on their own. The Congressional Budget Office projects that the combination of new federal subsidies for insurance and consumer protections will newly insure at least 27 million people by 2021. The PCIP program was one of several provisions of the law that went into effect in 2010 aimed at providing a bridge to 2014 for people who have been particularly at risk of being uninsured or poorly insured. About 135,000 previously uninsured people with health problems who are not able to gain coverage in the individual market because of their health have enrolled in the PCIP program since 2010. The program has succeeded in providing transitional support for thousands of people who were uninsurable in the individual market. The 50-state program provided more affordable coverage than people could gain in most existing state high-risk pools, which operate in only 35 states. And unlike most state high-risk pools, the PCIP program offered immediate coverage of pre-existing conditions. But the program's limitations were expected from the outset and demonstrate why high-risk pools in general are an inadequate substitute for the comprehensive insurance market reforms and expanded health insurance options to go into effect under the Affordable Care Act next January. The PCIP program's low enrollment relative to the millions of uninsured Americans with serious chronic health problems reflects the program's lack of premium subsidies. This means that its potential benefits are out of reach for the vast majority of this population. 79% of the estimated 7 million people who have a high-cost health problem who have been uninsured for at least 6 months have annual incomes of less than 400% of poverty. Half have incomes of less than 200% of poverty. In the Texas PCIP program, the annual premium for a plan with a $2,500 deductible is about $3,800. For a person with an income of about $11,000, the premium would comprise 1/3 of his income and the deductible 22% of his income. Like the existing state high-risk pools, premiums in the PCIP program have run well short of claims costs. Jean Hall and Janice Moore found that medical claims relative to premiums or the medical loss ratios in both state high-risk pools and the PCIP program exceed 100%, but that the PCIP medical loss ratios are as much as 7 times that of high-risk pools in some states. This difference in medical spending between the two risk pool programs is likely because the PCIP program provides immediate coverage of people's health problems. Combined with the fact that people must be uninsured for 6 months, this has likely led to an overrepresentation of people in the program with serious health problems that have gone untreated for a long period of time. The top 4 diagnoses or treatments in the federal program in the federal PCIP program are cancers, heart disease, degenerative bone diseases, and follow-up care after major surgery or cancer treatments. These conditions comprise more than 1/3 of claims cost in the federal program. The experiences of both the PCIP program and the state high-risk pools demonstrate the profound inefficiency of segmenting insurance risk pools. Without the benefit of a broad and diverse group of insured people, both programs operate at a considerable loss and depend on federal and state financing to fund the enormous gap between premiums and claims costs. Still, because of the high premium costs, both programs suffer from low enrollment. The Affordable Care Act's insurance market reforms take effect next year, making it possible for people with health problems or who are older to purchase a health plan with a comprehensive benefit package. Expanded eligibility for Medicaid and premium tax credits for private plans sold through the new insurance marketplaces means that people with low and moderate incomes with health problems will face far lower premiums than they do now in the PCIP program. For example, a 50-year-old man with an income of $23,000 would contribute about $1,400 annually for a private plan offered through the state insurance marketplaces next year. In contrast, annual premiums for 50-year-olds at this income level in the PCIP program exceed this contribution by nearly 2 times in Virginia, which has the lowest PCIP programs, to more than 10 times in Alaska. Starting in January, enrollees from both the PCIP program and the state high-risk pool will join millions of new enrollees in the new state insurance marketplaces with a diverse age and health profile, which will help spread the costs of care across a much broader risk pool. One of the central goals of the Affordable Care Act is to pool risk in insurance markets far more broadly than is the case today. Extensive segmentation of risk in insurance markets has fueled growth in the number of uninsured Americans over the past several decades. The experience of both the PCIP program and the state high-risk pools underscores why a shared responsibility for health care costs across the population and the life cycle is essential for an equitable and efficiently run health insurance system. Thank you.
Chair, thanks, gentlelady. Mr. Pollack, you're recognized for 5 minutes for opening statement.
Well, thank you, Mr. Chairman Pitts, and thanks for your graciousness in hosting this hearing. Thank you.
Turn the microphone on.
Is your microphone on? Just poke, yeah, until you got it ready.
I turned it off.
Okay, that's
Sorry.
right.
So let me thank you again, Mr. Chairman, for hosting this hearing and chairing this hearing, and thank you, Mr. Vice Chairman, Dr. Burgess, for this hearing. You know, pre-existing conditions is obviously a very important matter with respect to what we should do for the large number of people who are affected by it. I took a look at the statistics for Texas and Florida, for Pennsylvania, get a sense of how many people have pre-existing health conditions, looked at the totality of them. So in Pennsylvania, more than 1 out of 4 people between the age from birth through 64 have a pre-existing health condition. In Texas, it's 22.5%. Obviously, the older you get, those between 45 and 64, in Pennsylvania it's 48%, in Texas it's 46.4%. Now, we're obviously not talking about all these people in this hearing, and that's because most of them get protection because they have employer-sponsored insurance, and we think that's good. So what do we do with respect to employer-sponsored insurance, and what can we learn from that? Well, in employer-sponsored insurance, we do not deny coverage to people because they have a pre-existing condition, and we think that's good. Employers don't typically ask new employees, do you have diabetes, do you have a history of cancer, do you have heart problems, and they don't charge discriminatory premiums based on health status, and we think that's good. We don't deny coverage for clinical care that may relate to one's pre-existing condition, and we think that's good. We don't charge a prospective woman employee a higher premium because she's more likely to be pregnant than one of her male colleagues, and we think that's good. We don't charge those of us who have a few gray hairs a whole lot more in terms of premiums because of our age, and we think that's good. And for workers who have difficulty paying for premiums, say a middle-class worker who might be getting a salary of $60,000, and yet family health coverage now averages over $15,000, one-fourth, we provide them with help. Employers provide and pay for a substantial part of the premiums, and we think that's good. Well, as more and more people lose employer-sponsored insurance, either because employers are finding it too expensive or more employees are going into part-time work or functioning as contractors, I think there's a lot we can learn from that. And the Affordable Care Act helps us do that. Because in the individual marketplace, what the Affordable Care Act will say, just like we do with employer-sponsored insurance, you are not to deny coverage due to a pre-existing condition. You're not to charge a discriminatory premium because of your health status. You're not supposed to deny clinical care to somebody that fits with their health care problems. We will not charge women a discriminatory premium. We're going to limit the differential in what is paid in what people who are older have to pay as premiums compared to younger people. And we provide premium support for those below 400% of poverty. And by the way, with respect to premium support, in Pennsylvania there will be 896,000 people eligible for premium support come January 1. In Texas, it will be 2.6 million people. The point of all this is that the Affordable Care Act creates systemic change starting January 1 that is truly responsive to the needs of those people who have pre-existing conditions. And while we support changes that would enable those people who right now during this transition period cannot get into the PCIP program, that should not be done by undermining the more permanent changes that should be made and will be made under the Affordable Care Act. Ms. Surface talked about two different changes in her testimony about there no longer being a 6-month wait and the need for premium assistance. We agree with her. Of course, those things would occur starting January 1. So our hope is that there will be clear recognition that come January 1, we have a much better way to deal with those folks who've got pre-existing conditions, and it will work in a way that is truly helpful to them.
All right. Chair thanks the gentleman for his opening statement and recognize Mr. Miller 5 minutes for your opening statement.
Thank you, Chairman Pitts, Vice Chairman Burgess, and members of the subcommittee for the opportunity to speak today on protecting America's sick and chronically ill. Pre-existing condition insurance plans, or PSIPs, represented a poorly designed, half-hearted gesture within the Affordable Care Act. It was aimed primarily at minimizing political risks rather than addressing a serious problem more immediately and comprehensively. PSIP coverage served more as a cosmetic patch to cover the consequences of slow implementation of complex coverage provisions scheduled to begin nearly 4 years after enactment of the ACA. The program never received sufficient funding to do its job seriously. The relatively small amount of funding and limited attention to the program's structural details appear to conflict with the exaggerated rhetoric of the Obama administration in claiming that the extensive problems of lack of coverage for tens of millions of Americans with pre-existing health conditions were the primary political rationale for enacting the ACA's regulatory coverage and financing provisions. The political ideology behind the core policies of the ACA to install guaranteed issue, community rating, mandated coverage, richer standard benefits, and federal regulation of health insurance trumped targeting the smaller but significant problem of several million Americans with limited or no insurance coverage due to serious pre-existing health conditions and addressing it more effectively. The PSIP program managed to solve less of the problem, enrolling fewer Americans than traditional state high-risk pools had enrolled, but at a higher per-person cost while still running out of money. Pretty good for government work. At the same time, it discouraged continuation beyond 2013 of better tested state alternative mechanisms, the better funded high-risk pools. By setting its premiums for all at no more than standard rates, contrary to the better practices of the older state high-risk pools, or HRPs, and also imposing a 6-month spell as uninsured to qualify for coverage, PSIP only succeeded in mostly enrolling very desperate, high-cost individuals who had no other alternatives for coverage. Now, states administering pre-ACA HRPs did a better job by charging enrollees somewhat higher premiums, offering less comprehensive coverage, and focusing on those individuals who presented the most serious and costly medical conditions. However, they too still need more robust sources of funding to do their job more thoroughly and effectively. But remember, simply trying to average or hide the same total health care claims costs across a somewhat wider base, that's the ACA approach, it may redistribute them, but it doesn't reduce those costs. If the forthcoming health exchanges are plagued by premium spikes, implementation misfires, limited enrollment, and adverse selection, they may end up more closely resembling somewhat larger versions of state-level PSIPs than more competitive alternatives to the current private insurance market. A policymaker should consider the following 10 points. 1, recognize that healthcare markets are local, not national. So too are problems for persons with high-cost conditions. 2, the rhetoric of delegating administration of sensitive health policy provisions to state governments needs to be matched by the reality of federal officials letting go of tight reins and trusting state officials with more discretion over eligibility, benefits, and appeals issues within much broader outcome-oriented federal parameters. 3, be very cautious about imprecise estimates, and they're often guesses, regarding the scale, scope, and cost of the medically uninsurable and others with inadequate resources to handle very high-cost, high-risk health conditions. 4, we should commit a generous amount in a series of capped annual appropriations to support continued operations of state HRPs and or restructured PSIPs, to be revisited upon subsequent evidence of larger enrollment demand or higher but medically necessary costs. 5, publicly subsidizing the high-cost tail of health risks can strengthen the rest of the private health insurance market. 6, raise unsubsidized premiums charged for most enrollees in high-risk pool plans to at least 150% of standard rates, but then provide income-based subsidies for lower-income people. Separate the issue of income support from that of protection against losing or lacking coverage solely due to elevated personal health risk. 7, complementary policy reforms can help, such as better portability from group to individual market provisions with creditable coverage, no longer requiring exhaustion of COBRA benefits, retargeting premium subsidies, and building information transparency mechanisms that reward better patient choices and provider practices. 8, keep as many older state HRPs as possible in business after 2013 as an insurance policy against major problems in exchange implementation and individual mandate enforcement or compliance. Allowing such coverage to be considered qualified insurance under ACA would minimize post-2013 disruptions in the continuity of coverage and care. 9, if the overall costs of health care don't rise more slowly and individual incomes don't rise more rapidly in the near future, no amount of subsidized insurance tinkering can keep up with the larger problem. Finally, the pre-existing condition issue is still a largely limited, modest problem. Solve it instead of using it as a political excuse to politically hijack the rest of the private insurance market. Thank you.
The chair thanks the gentleman, thanks all the witnesses for their opening statements, and I will now begin questioning and recognize myself 5 minutes for that purpose. Mr. Miller, let's just continue with you. You've given us a great list. When Obamacare was enacted into law, you wrote that the program was designed in a way that would lead to inevitable problems. What principal feature, or the principal features, if you could name a couple of PSIP, led you to believe that the program would run out of funding?
The program was weighed down by the larger law itself of the overall program, but within the provisions of PSIP, the two core provisions, of course, are designing it with the 6-month requirement for uninsured coverage, which created a flaw in it from the start, and secondly, the massive underfunding relative to what the potential range of the problem was. The only reason why some budget estimates said, well, we might get under the wire on this, CBO simply said, well, they'll close down the program when they run out of money. And the actuary, who readjusted a little bit of the original program from HHS, basically said the same thing. They have provisions written into the law for the PSIP administrators, or HHS, to carry out the worst practices of the private insurers they blamed, which is as soon as we run out of money, we hollow out the benefits, we close the doors, and therefore we've met our budget. And it's not surprising that we got there. Maybe we got there a little later because it was a slow take-up, but in essence, it was a program designed to have an early expiration date on the cover.
Thank you. Governor, you mentioned a number of administrative problems and litigation. Are you still having administrative problems with the feds or with HHS regarding the administration of your pool? All the litigation solved, or
the most recent lawsuit we've come to an agreement on the resolution of that. As I did say in my testimony, we are pleased that the Department of Insurance continues to be seen as the regulatory arm of health insurance in Ohio, at least as it relates to the high-risk pool. So at this point, the two major issues that we faced, both the rate issue in 2011 and protecting consumers and protecting consumers' coverage in Ohio, have both been resolved.
Okay, thank you, Ms. Surface. Can you describe your thoughts at the time when you found out that PSIP was not an option due to HHS closing the program to new applicants?
I can try. It was sort of an interesting experience for me. I had, as I indicated in both my written and my oral testimony, started in February trying to figure out how I would now begin to finance this very expensive health venture. And one of the things that I came across was the Ohio High Risk Pool Insurance. I saw my specialist at the end of February, and at that time my specialist indicated to me that he would like for me to enter into a clinical trial that's having very good results for lenalidomide in the treatment in my specific chronic lymphocytic leukemia, which is chemotherapy resistant and a bit more aggressive due to chromosomal mutations. So he had suggested that I go ahead and enter into that clinical trial. At this time, I actually took some time to step back from that, being basically healthy at this point, and said, I think I want to take a little bit of time and watch my numbers and see exactly what this cancer is doing inside my body and what I need to do to manage it at this time. It was within about a week and a half, 2 weeks from that point in time that I found out that maybe I don't have the time to step back and do that, because if I don't enter into that clinical trial more sooner rather than later, then it's likely that that trial will fill up and there won't be any type of reasonable, affordable treatment option available for me. So I really had to step back and assess what I'm going to do with regard to my health care condition at this time.
Now, because you are self-employed and not able to work at this time, as I understand it, your treatments are covered by Ohio's Hospital Care Assurance Program. Is that correct?
At this time, as long as I take my care through Ohio State Medical Center, I do qualify under their regulations for the HCAP program. And in fact, there's a separate program administered for OSU physicians. So as long as the part of my care that's managed at OSU Medical Center is actually covered on a quarterly review basis, so each quarter they'll flag my status and I'll have to resubmit income, profit, and loss information for that.
So as long as your income remains below a certain level, this program will cover you?
Yes, sir.
And are you saying that it would be more beneficial for your health to not work and be covered by HCAP than to work full-time, surpass the income minimum, and have no coverage at all?
I would argue that it's never more beneficial for my health for me to not be working. Both mentally and physically, it's better for me to be as active as I possibly can be. From a financial standpoint, it may look like, at least on paper, that it would be more beneficial for me to choose not to work, or at least not to work at a full capacity, in order to maintain health care.
My time's expired. I have a lot more questions for you, but let's go to the Vice Chairman, Dr. Burgess, for 5 minutes for questions.
Thank you, Mr. Chairman. Ms. Surface, let me just ask you, you're an attorney. I actually am a physician in my previous life. So we both are in professions that are there. We went into them to help people. And if I understand your testimony correctly, you, in fact, function as a public defender at some point. Is that correct?
Somewhat. The program that we have in my county is called Court-Appointed Counsel. All of the attorneys in our area that practice criminal law actually serve as court-appointed counsel, but it is very similar to the public defender program.
And you, of course, are paid for that work, are you not?
I am.
And where does that payment come from?
That money comes out of the county fund. Our county commissioners establish an hourly rate for our court-appointed counsel.
Well, wouldn't it be better if the federal government just took that over and we paid you for that?
Oh,
you don't have to answer the question.
I was going to say,
it's rhetorical.
It's a very rhetorical question. I wonder. I wonder how where that money would come from with regard to the federal government, and why would it be better for the federal
place all of the money comes
government?
From. We just take it from someone else at the point of a spear, and they give it to us willingly after we threaten them with lifetime incarceration and impounding of all their personal property. But, Lieutenant Governor, your discussion of how difficult it is to work with Health and Human Services and Center for Medicare and Medicaid Services, to me that would be an argument against the federal government taking over that program that the county is so ably administering and taking care of those people who get into trouble with the law but are too indigent to afford their own lawyer. Would that be a correct assumption?
Mr. Chairman, Dr. Burgess, yes. Our experience specifically with the high-risk pool, working with HHS, working with the federal government, has proven to be less than rewarding. I think states are well prepared to regulate insurance, as we have done for the decades. And I think that these types of issues are best addressed closer to home, where you can react quicker and in a more thoughtful way with regard to market changes, economic conditions, the needs of your citizens. Long way of saying yes.
Yeah, you can react quicker, and that's important, and you know the people with whom you are dealing. I mean, your state is arguably a little different from my state, and the needs and the things that would need to be met for the constituents might be different in the two states, and you're in a position, and your counterpart in my state would be in a position to make those, to have the facility to be able to make those decisions on a much more real-time basis. I just have to tell you, I mean, I sat down with your counterpart in my state on Monday, and of course, the little far afield from what we're talking about today, but the Medicaid expansion, which is being much discussed, and the litany of complaints that come forward from the state folks about trying to deal with the Center for Medicare and Medicaid Services. They have created a regime over there which is almost impenetrable. So is it any wonder that no one at the state level wants to buy? They don't want to buy any more of that. They've had enough of it, and I certainly understand that. And I think, Mr. Miller, I remember back to 2008, and we actually talked about this issue of the state risk pools a lot back in that year, as I recall. I don't remember why we discussed it, but we did. And I got to tell you, I was a little bit encouraged after the summer town halls of 2009 that I alluded to, and those were somewhat rough events. But we came back to Washington in September, and the president was going to address a joint session of the House and Senate. And I thought, oh, good, they've realized the error of their ways, and they're going to put the pause button on here. We're going to hit the reset button. But alas, I was mistaken. It was fast forward, if anything. But one of the things the president said that day that really got my attention, or that night, and it really got my attention, was that Senator McCain was right with his approach to helping people with pre-existing conditions, and these expansion of the state pools and reinsurance. That might be the way to go. And I thought for a brief moment there was a glimmer of understanding, but what do you think happened?
Well, they had some of the music, but not all the lyrics. Consensus is often a mile wide and an inch deep in those type of things. And that was in a compromise moment to try to get some type of legislation through while bowing in the direction of temporary bipartisanship. There are always seeds of agreement between the two sides, and then we kind of get overpowered by broader imperatives to get it all and to implement your program and get it, comprehensive. You can find Republicans and Democrats agreeing we need to help people who are in desperate straits, who can't help themselves. We need to be generous and kind and compassionate as a good society. But there's a difference between doing that and running everybody else's life in micro detail. And that's what we got as kind of the loss leader was, we'll do some things for some people we can give you an anecdote about, but meanwhile look at the rest of what the law is going to do. It's turning upside down what are the arrangements that people are quite happy with and would like to continue, and they're going to be in a very different world within a year. All these ideas that somehow waves of happy, young and healthy people will be ready to pay twice as much in their insurance premiums and everyone will come out ahead and everybody will be subsidized. It's not going to work that way. And that's the problem in trying to shoehorn people into theoretical arrangements that don't match their preferences and practices.
Thank you, Mr. Chairman.
Chair, thanks, gentlemen. We're going to continue with another round. We've got lots of questions here. So let me continue with you, Ms. Surface. What are you planning to do now that funding for the new enrollees in the PSIP program has been pulled by HHS?
I'm going to take it one day at a time. I have no choice but to continue with my medical care. So I'm going to continue making my appointments and managing my care as best I can. Do my very best to not incur great expense to myself and see what's available for me. I'll take advantage of the HCAP program and any similar program that's available. I'll take advantage of whatever Leukemia and Lymphoma Society is able to offer. And I'll just take it one step at a time.
The added burden of not knowing if your CLL treatments will be covered must add unneeded stress to your life as a single mother, does it not?
It sure does.
Mr. Miller, after HHS's announcement that new applicants would be shut out of the pre-existing condition program, we sent a letter to the President asking to work together to redirect funding in the President's health care law to ensure that no sick American is turned away. And as I mentioned, 1 month later, we have yet to hear from the President. My understanding is that at the time of enactment, roughly 18 programs in PPACA received greater or comparable funding than the pre-existing condition program. Couldn't this funding, such as the mandatory appropriations in the Prevention Public Health Fund, provide the resources to help enroll new individuals in a high-risk pool program?
It could certainly help contribute to it. The administration apparently has broader priorities which look more at 2014 than what people are going through in 2013. I know some of the money has been taken out of the Prevention and Public Health Fund for the doctor fix, so it's kind of a bit of a basket that gets raided several times. There might be, I think, $8 or $9 billion, depending on how you want to count it, for the remaining authorization there. That could certainly make a contribution to provide real relief of a tangible nature. A lot of the stuff in the Prevention and Public Health Fund is a little bit more on the exotic side. It could be done in the right way, but we don't have much evidence that it's actually working in that manner, a little bit more of a political slush fund. So that would provide some means of a contribution. We'll need more money than that if you wanted to do this on a longer-term basis, and I think there have been previous proposals for more enhanced funding in a different environment, and I'm not sure if the votes are there to get that right now. But when you're looking at people who have a very identifiable condition, you know, these are the folks who you'd want to put into a special needs plan. We know they've got a serious condition. They need actually more intensive medical management. You'd like to coordinate. You've already identified the population. It's going to cost money to subsidize them. That's something we should do, and that should be a higher priority, perhaps, than subsidizing everyone's insurance all the way up to 400% of the federal poverty level. But that's the different political agenda than helping the most unfortunate people right now in ways that can help.
Dr. Collins, in your opening statement, you said that PSIP provided immediate coverage for pre-existing conditions. However, this leaves out an important context. Didn't the ACA require patients to be uninsured for 6 months before they became eligible for PSIP?
Right. So the intent of the PCIP program was to provide immediate coverage for people who had been insured for a long period of time, or at least 6 months, and to immediately cover their pre-existing conditions. As Mr. Miller pointed out, most state high-risk pools do not cover your pre-existing condition right away. So the intent of the law was to cover people's conditions immediately. The intent was also to provide insurance coverage to people who didn't have health insurance coverage. So that was very clear in the law. It was designed as a transitional provision so that people who are uninsured, who had immediate health care needs, could get coverage over this 3-year period.
Well, Ms. Surface's testimony indicates that this requirement had real effects on patients desperately seeking coverage for a pre-existing condition. Didn't this requirement essentially force patients to let their conditions deteriorate while they waited for ACA's arbitrary 6-month waiting period to run out?
It was certainly difficult for people who had to wait to get coverage. It's one of the characteristics of our current insurance system that will go away next year, where people are prevented from pursuing careers like Ms. Surface is right now, in terms of having more flexibility in their jobs, their educational pursuits, because they have to not make above a certain amount of money to maintain their health insurance coverage. All that goes away in January, so that people don't have restrictions on what they can do anymore in their careers just to maintain their health insurance coverage. So this was, again, a transitional provision. There were several transitional provisions in the law. This wasn't the only one. The ban on lifetime benefit limits, the phase out of annual limits on health, what health insurers can place on your benefits. So this was part of a large number of provisions that went in right away that did provide coverage to a lot of people who really needed them. Young adults, about 6 million young adults came onto the parents' policy over the last year. So they were in no way designed as the end point in the
Okay.
provisions, but as really a beginning point at transition.
I wanted to get one more question in. Mr. Pollack, does it concern you that the administration has cut off funding for this program?
Obviously, I'd like to make sure that everybody who has a pre-existing health condition can get coverage. And it is very concerning that people who have a pre-existing condition, like Ms. Zerfas, are right now without the opportunity to get the coverage they need. But what is very important in terms of the compassion that we've all talked about with respect to people with pre-existing conditions is that come January 1, all these problems are a thing of the past. People are not going to have to wait 6 months in order to get coverage. People are no longer going to be put in a totally different pool just because they've got a health problem. People are no longer going to be charged a discriminatory premium because they've got a health problem. So to the extent that you, Mr. Chairman, and Mr. Vice Chairman are interested in fixing this temporary problem with additional funds, we support that, but not by undermining the long-term architecture of the legislation, which is going to be far more effective than this temporary measure.
Thank you. My time has expired. Dr. Burgess, you're recognized for another 5 minutes, second round.
Undermining the long-term architecture. Well, that's an elegant way of talking about something when in reality, what we should have been told 3 years ago before this thing was signed was the dog ate my homework, so I'm going to turn in the rough draft. And Ms. Zerfas, in her testimony, talks about how this particular provision was not in the bill that passed this very committee on the House side in July of 2009, but it was added to the Senate Finance Committee staff added it. In fact, most of this was written by the Senate Finance Committee staff. It wasn't even written by legislators. And the thing was rushed through on Christmas Eve. There was a big snowstorm coming to town, and the senators wanted to get home for Christmas, so they had to vote on it. And they voted, and they got 60 votes for the Affordable Care Act. Now, everybody felt, I'm sure Chairman Waxman, if he were here, would tell us that he was working on the conference committee, even between Christmas and New Year's that year. He was preparing himself for the conference committee. The president came to the Democratic retreat that year, and all the discussion was how we're going to get this ironed out even before the conference, and we'll get a bill that both the House and the Senate can support. But it didn't happen, did it? Because there was a special election in Massachusetts. Scott Brown was elected, first time a Republican was elected from Massachusetts since the earth cooled the first time, and there were no longer 60 votes in the Senate. So Harry Reid told Nancy Pelosi, this is it. This is what you get. I can't change it. So most people don't realize this. H.R. 3590 was the bill that was voted on Christmas Eve. 3590 was passed by the House of Representatives in July of 2009. But it wasn't a health care bill then, was it? It was a veterans housing bill. A veterans housing bill passed the House. I don't think many people voted against it. It went over to the Senate, sat in the hopper, and then it was amended. And the amendment read, strike all after the enacting clause and insert, and this is what was inserted. So here you had a bill that had passed the House, different form, passed the Senate, came back over to the House, and if you don't change anything, you can sign it into law. And that's what the next 3 months was all about. How to convince enough Democrats to vote for really what was a rough draft. It would never have done what this thing has done to Mrs. Zerfas if it had been fixed. But there was not the ability to fix it because there weren't 60 votes for any type of fix in the Senate. It was the very worst type of process that gave rise to the very worst type of policy, and then for reasons that I'll never understand, got signed into law, and we're having to deal with it, and we can see it affects real people in very profound ways. Now, I would submit the letter that the chairman referenced to the president, and I realize it's just a Band-Aid on a problem, Mr. Miller, but the Prevention and Public Health Fund, yeah, we've rated it for a lot of things, Trade Promotion Authority, Doc Fix, so let's rate it for this as well. I mean, goodness knows it is a political slush fund. It was added again, by Senate Finance staff for reasons that I certainly am not privy to. I think, Mr. Chairman, perhaps we can submit again to the President that he reconsider his inaction on this, because we've heard testimony from compelling witnesses today that something needs to be done. Before we can all lay down in the Elysian fields of the Affordable Care Act on January 1st, 2014, we're going to have to deal with this. And the Public Health and Prevention Fund, I think, is the logical place to go. If there's not quite enough money there, then certainly let's go to the Patient Center for Outcomes and Research Initiative. There's another place where a lot of dollars are just sitting. The Center for Medicare and Medicaid Innovation, a lot of dollars are just sitting. There's no reason to have them just sit there. Let's let them help real people and help real people today. Now, Mr. Pollack, in your testimony, you said, your calculation, 68 million people have pre-existing conditions, and 100,000 are now covered under the federal PSIP program. There's a bit of a discrepancy between those two numbers, isn't there?
Of course there is, and I explained that. The reason there's such
and
a,
I accept
the reason there is such a
explanation.
discrepancy with
But
respect to that,
Let me ask you the
explained
question,
right at the
sir,
beginning,
before my
is
time
that
runs
most
out.
of those folks are in employer-sponsored insurance.
Correct.
And it has the same attributes
And
of
those
the protections that will now
those
be
very
provided
folks
in the
begged
individual
us,
market.
begged us not to disrupt what they were receiving, and it looks like we have. But let me ask you a question. If you thought that this was as serious a problem as it was the administration wrong in only putting $5 billion toward this problem?
Would I favor more money put into this as the temporary measure? Of course I would. I certainly would like to see the temporary problems that are significant problems, that they be fixed, but not by undermining, as I said before, the key architecture of the Affordable Care. Whether it is a prevention care fund, which is very important to promote good health care, it shouldn't be sickness care, it should be health care.
But, sir,
And I don't think that we should be undermining any
reclaiming my
research with
time.
respect to clinical
The
guidelines.
architecture underlying the Affordable Care Act is anything but elegant. It's bizarre. It would be the nicest way to describe it. It's macabre. And honestly, I cannot, if the money is there in other programs, Mr. Chairman, I cannot see why the President, the Secretary have not responded to what is a very reasonable request that this committee has submitted in written form. And I will just reiterate that I think they should respond, and if they don't, I believe we should ask the question again as nicely as we possibly can. I'll yield back.
Chair, thanks, gentlemen. We're going to go to another round, if that's okay. I still have some questions. I think you do. Governor Taylor, in your testimony, you state that Ohio commissioned a study to estimate the effects of PPACA on premiums when the law is fully implemented. It found that premiums will increase by as much as 85%. Recently, the Society of Actuaries issued a report with a similar finding, estimating that Ohio's individual market could see premiums increases as high as 80%. Do these estimates lead you to believe that many will forego coverage because of the ACA's costly requirements?
Mr. Chairman, we are clearly concerned by the changes that will be implemented starting in 2014 that are going to very severely negatively impact the cost of premiums in Ohio. Both studies are somewhat consistent in that premiums in our individual market will rise by as much as 85%. Of course, from a state perspective, yes, I'm concerned. I would prefer to have more flexibility to come up with individual state solutions that solve Ohio's problem and Texas solve your problem the way it best suits Texas. And I think given some flexibility, our goal would be to use a more market-based approach and help make the cost of insurance more affordable and more accessible using free market approaches rather than providing federal subsidies that I think the high-risk pool is a somewhat look at what we might expect in the future, where you have premiums being artificially held down by companies who are pressured by HHS, and then ultimately premiums aren't covering the cost of the type of care that's being provided. And as a regulator, one of our primary concerns is, of course, solvency of the companies. Consumers are severely harmed if companies don't have enough capital or reserves to stay in business to pay those claims, and ultimately it's the consumer who will suffer. So my preference would be back to a market-based approach that reduces the cost of premiums for everyone and makes it more affordable and more accessible that way.
Would you continue to elaborate on what efforts Ohio is undertaking to reform health care in Ohio?
Yes, Mr. Chairman. Well, as I stated in my testimony, unfortunately, a lot of what we see in the ACA is not dealing with the root of the problem, which is how you actually drive down the costs of health care. Really, it's more just insurance regulation or changes in insurance regulation. In Ohio, we have our Medicare and Medicaid groups working together so that they're coordinating the coverage of individuals that are eligible under both plans in order to save money. We have an Office of Health Transformation that is working with individual providers, hospital providers across the country to help better coordinate care between those that receive services for mental health, for example, and then also how they receive services for physical health, doing a better job of coordinating those services to help drive down cost, using technology and to look at how we provide better care for patients, higher quality at lower cost. So working both on the Medicaid side, but also then working on the more private sector side by partnering with providers across the state. And ultimately, it's allowed us to hold down the increases that we would have otherwise seen in Medicaid so that we can have more flexibility with how we manage the Medicaid program. And also, the governor has broken out in this most recent budget, separately identified our Medicaid director as a cabinet-level director versus working for a different agency.
Now, based on the problems you've dealt with already, could similar regulatory problems occur? Do you foresee your state having additional problems with the implementation of the Affordable Care Act once the law is fully implemented?
Mr. Chairman, I guess if we look back at our experience with the high-risk pool, and I guess the statement is pretty much true that if you want an indication of the future, look at the past. Of course, we're concerned about disagreements with federal regulators, both as a state regulator, but then how does that impact consumers, ultimately impacts consumers, impacts companies, creates uncertainty in the market, which makes it much more difficult from an administrative perspective for all of us to deal with the difficult issues. Of course, we're concerned about the premium increases and the costs that that will bring. If you look at Ohio's high-risk pool, just as an example, we have about 3,500 people covered in our high-risk pool, and the cost ultimately we're projecting costs being paid for by the federal government somewhere between $135 million and $140 million to provide subsidies for that care. So of course we have a cost issue, and then of course I've already stated the concern we have with artificially holding down premiums that ultimately puts at risk the companies that are there to pay the provider claims and pay the claims for consumers.
Thank you. I want to sneak one more question in here, Ms. Surface. Your situation's not a special case. Can you talk a little bit about the number of patients who you referenced in your written testimony who are facing the same government barriers as you do?
My situation is not a special case, and I think that's why I'm here, is because it's becoming almost the rule as opposed to the exception, especially now that there's not the funding available for this pre-existing condition insurance program available right now. I believe that we submitted about 8 different testimonies in the written transcript that was provided to you. Each one of those people is obviously too sick to be before you today, which is why I'm representing those people as well. The problem that we have in trying to identify how many people are being affected is we're only aware of the people who are being affected when they contact us directly. So we don't know who is having trouble, who got kicked out of a program, who applied too late to be permitted into the program. We don't know those numbers right now. I do know that the Leukemia and Lymphoma Society is working on making sure that we can have additional data to submit to the committee, and we would be happy to provide more written information to you. But at this time, the only people that we have direct information on are the ones whose stories are already in the record.
Now, how did you hear about the Leukemia and Lymphoma Society, and how have they helped you through this trying time?
I had a magnificent experience with the Leukemia and Lymphoma Society. In 2005, shortly after my grandmother had been diagnosed with non-Hodgkin's lymphoma, I joined the Leukemia and Lymphoma Society's team in training and became an advocate and a fundraiser for them through cycling. So I did that for a season, and then many of my friends that I met through that excursion remained advocates for team in training. So I was already familiar with the Leukemia and Lymphoma Society when I received my diagnosis in January, and they were one of the first resources that I looked up to determine whether there would be any type of premium assistance available in the event. As I am self-employed, one of the things that does happen is I can't say I have X amount of dollars available for monthly income. So on a month-to-month basis, my income may change and fluctuate. So I may have a good month followed by a bad month. And I'm sure that a lot of people who are self-employed understand exactly what I mean by that. So what I would need is something to fall back on, a fallback position, to even be able to make those premiums on a regular basis, to make sure that I don't have a lapse in care once I'm able to become insured. So I was researching that issue and came back in contact with the Leukemia and Lymphoma Society, who actually provided a symposium in March in Cincinnati, and I attended that symposium and reconnected with the agency. So they do have a lot of resources available for people in my situation.
Thank you, and again, thank you for sharing your personal experience and represent the other patients that you've referenced. Dr. Burgess, you're recognized for another 5-minute round.
Thank you, Mr. Chairman. Are you sure you want to do this? Well, let me just ask you, Surface, you're a lawyer. I mean, you followed what happened in the Supreme Court last year, and a lot of the argument that was brought against the Affordable Care Act was based upon the constitutionality of using the Commerce Clause to compel the purchase of health insurance. Now, had the individual mandate existed 3 years ago, would you have had health insurance?
If the individual mandate had existed 3 years ago, it would appear that I would have been mandated to have insurance. So By nature, yes, I would have to say I would have had insurance 3 years ago prior to the time that I would have been diagnosed with this illness.
Except that those things that were a barrier for you to purchase insurance 3 years ago would still have been a barrier. I mean, the cost. You yourself point out how your income can fluctuate quite a bit during the year. One could even visualize a scenario where at one point you might be eligible for the Ohio Medicaid expansion at under 138% of the federal poverty limit. At another point, when you get a lot of work, you might be making too much money to qualify even for the subsidies in the exchange. And of course, as you know, people who then earn more income than would have allowed them to receive a sub, you don't know going into a year what kind of year you're going to have, do you?
No, not at all.
As far as your billings and collections. So you may be eligible for a subsidy and receive the subsidy, but you know what? At the end of the year, we may ask for that subsidy back because you've had a good year.
Sure.
So it is not quite as straightforward as just, yeah, if the mandate had been there, I probably would have had insurance. The barriers would have still existed, I submit, that the very things that prevented you from purchasing that insurance 3 years ago will in fact still be there for people who are now simply required to buy insurance. And some will because, well, it's the law, I got to do it. And others will, no, it's still too expensive, it's still too much of a barrier. The fine is relatively modest, at least for several years. For a single individual earning under a certain level, it's $600 or $700. And yeah, if they catch me, then fine, I'll pay the fine. But otherwise, I can make a payment on a bass boat for what I can buy health insurance. And a lot of people are just simply going to elect not to do that. So I don't know if we have changed it. Mr. Miller, you're bound to have some thoughts on the concept of whether the individual mandate will change the behavior of people who are looking at the insurance market and are kept out of it because of some of the barriers that have been discussed here today.
Well, CBO relied upon a small sample size of Massachusetts to basically make its projections on coverage take-up. And although they've covered their tracks a little bit since then, they were assuming that people would just be good Americans obeying the law. And the mandate as a command was a big factor in its projections of the take-up, not just the subsidies alone. They haven't really dialed back on what those assumptions are in terms of what would be the coverage from the mandate, which is now just seen as a tax. And when you see things as a tax, other people have looked at this and said, well, you're going to make a financial calculation. Do I pay a small tax or do I pay a much higher premium? Particularly if those premiums for some individuals are going much higher than what it actually costs them in insurance. So there's a lot of skepticism as to how effective the weak mandate as it currently exists, both before and after the Supreme Court, what it will really mean in terms of pushing people into the coverage to pay much more than they ordinarily would pay.
And there is still the safety net of community rating and guaranteed issue. You can buy the insurance in the emergency room or perhaps even in the ambulance on your smartphone on the way to the hospital after the accident.
Correct.
Not right?
I mean, we have Medicaid coverage, which is actually provided after the fact. That's been going on for some time, where you can sign them up in the emergency or in surgery, actually. And certainly, it depends upon all the regs aren't there as to how they'll handle the guaranteed issue under the Affordable Care Act, whether they'll have a waiting period or only a enrollment period for a couple of months. Let me just take a moment because I know we're about to finish. I sit here. I like to stand in astonishment. Ron means well and says a lot of nice things at the hearing. I read his report last summer for Families USA in July of 2012. There was no nuance in that. It was a screaming headline. Nearly 65 million Americans, at risk of losing their coverage, but for the Affordable Care Act. Not one word or sentence in there about all the protections for people with employer-sponsored coverage. This problem of overshooting the mark and saying, run for your lives, you're about to lose everything. HHS had a report in 2009, had over 125 million people at risk. We marked down to 65 million in Ron's report. Then we had another one by Commonwealth, 12.5. When the serious people look at this and say, where's the problem, you get down to about 4 or 5 million where it actually matters, where people are not getting coverage. Now, to some case, they may get a little bit of a rate up in their premiums, which accounts for most of that. But we ought to talk about where the problem is and what the dimensions are. It's a serious enough problem without exaggerating it. And then we can deal with it in a forceful, effective way. But it's used to leverage a larger agenda, which is to rope everybody into something else, which we wouldn't support because you want to scare people that you're about to be at immediate risk when that's overstated.
I think
You know, it's not people.
well, I'm about to run out of time. In fact, I am out of time. But, Mr. Chairman, if I could, I'd just like to ask a question of Dr. Collins, because the issue of cost has come up, and the things that, of course, we were tasked to fix were pre-existing conditions, not messing up the system as it currently exists, and then to help people with cost. It looks like we failed on all 3 points. But on the aspect of cost, the Commonwealth Fund put out a paper in a few months ago from Minnesota that talked about, I think you called it the activated patient, where the costs were lower for someone who actually was an active participant in their care. And we had all the hearings leading up to the Affordable Care Act, and we heard from experts on Medicaid, and we heard from experts on this, experts on that, but we never brought in, say, Governor Mitch Daniels from Indiana, who, with his Healthy Indiana plan and creating that activated patient population, found that he brought his costs down significantly over a 2-year span. It seems like that would be a logical way to approach things. We're talking about states expanding Medicaid. We're not talking about people who are already mandatory populations. That is, people in nursing homes, people who are blind and disabled, children. We're talking about new coverage for basically for young adults who are healthy. Why wouldn't we use this activated patient model that the Commonwealth Fund wrote about in incorporating that expansion?
You know, I think you raised a very good point, and I think the discussion of cost earlier is really important. I think the viability of the Affordable Care Act and the coverage expansions over time will depend on the affordability of the premiums, but half the law does address the underlying cost drivers in the system through a significant set of delivery system reforms, a lot of which have already gone into place. I think the law also encourages, unlike some of the comments that have been made here, huge innovation at the state level. So states have enormous flexibility in designing their insurance exchanges if they want to do so. They also have primary responsibility for regulating their insurance markets. And the delivery system reforms, we're seeing a slowdown in healthcare costs over the last couple of years. Part of that is recession related, but part of that is probably structural. So we're seeing changes in the system that's both being driven by innovations like going on in Ohio, in Indiana, but also some that are being driven by incentives and new grant funding provided under the Affordable Care Act. This is a hugely important problem for the United States. It will determine the viability of the coverage provisions over time. There are insurance market regulations that do address premium growth. We've already seen a huge decline in the number of premium rate increase requests from insurance companies because of the rate review program that's been in effect for the last year. The medical loss ratio requirement is also having a huge impact. $1.5 million in rebates and administrative cost savings last year just as a result of that provision alone. So the Affordable Care Act is not just about coverage. In fact, over its 10-year budget projection, it actually reduces over the overall deficit because of these additional delivery system reforms in addition to the coverage requirements.
Well, you know, Governor Daniels said it in a piece in the Wall Street Journal several years ago now, even before, while we were still debating the Affordable Care Act, and that by providing his state employees with a high deductible policy for catastrophic coverage, and then providing them the funds to pay that high deductible should they be required to do so, allowing them to keep the money in those health savings accounts if they didn't spend it, he came to the conclusion that something magic happens when people spend their own money for health care, even if it wasn't their own money in the first place. And I don't know why there has been such a resistance to accepting that lesson that he's shown so elegantly in Indiana, and why we won't allow it to occur in more places. Lieutenant Governor, I will give you the last word. I rather suspect that the flexibility that Dr. Collins spoke about is something that you would welcome. Is that not correct?
Mr. Chairman, Dr. Burgess, yes. And I guess my comment with regard to all of the flexibility that has portended to be given to the states, both in how exchanges are organized. If you read the rules and regulations, if you look at least Ohio's history with dealing the high-risk pool, my definition of flexibility as it relates to dealing with HHS and CMS is you can have as much flexibility as you want as long as you do it my way. And unfortunately for Ohio, we have the experience that we have had little flexibility, and if there was as much flexibility as is being suggested, I think you would have less concerns or issues coming from individual state regulators who say, you tell us we can regulate our market, but when you disagree with what we have concluded as with the high-risk pool and whether or not individual consumers were eligible for coverage, it was up to us until you decided no. And that's unfortunately the experience that we have had.
Thank you, Mr. Chairman. My time's expired. I'll yield back.
Chair, thanks the gentlemen. We have other questions, but we'll ask the members to submit their questions for the record and ask the witnesses to respond promptly when you receive those questions. This has been an excellent hearing, very, very important issue. And I want to thank the witnesses for taking time to come and present their testimony. I remind the members they should submit their questions by the close of business on Wednesday, April 17th. So without objection, with thanks to the witnesses, this subcommittee is adjourned.